What's up, everybody? Welcome back to my channel. It's me, Kendra. In this video today, we are going to continue the conversation on home health nursing. Earlier on this week, I posted a video talking about the upside of home health. So in this video, I am going to give you the downside of what it is to be a home health nurse. And I have to be honest, I was making notes in my phone for this video about the con side of home health nursing. And I was actually re-traumatized all over again because let me tell you, I worked as a home health nurse for I want to say 5 years in total out of my nursing career. And it definitely had some stressful moments to it. So let's go ahead and jump right into it. Now, I do want to preface this by saying, as with any other profession or any other job within nursing, there's definitely pros and cons. I gave you the upside in the previous video, so I think it's only fair to give you the downside. I'm always going to give you my views, my opinions. It's mine. It's not written in gospel, so you don't have to believe everything that I say. Or if you want to go ahead, it's always best to experience it on your own so you can say, you know what, she was right. Okay? The first thing I want to talk about is the schedule. So in the first video, I talked about home care nurses being very autonomous with their schedule. You're given a group of patients to case manage, and you basically schedule them however you want to according to the frequency that they need to be seen. So for example, you have a patient that needs to be seen 3 times a week. Usually it's Monday, Wednesday, Friday. Twice a week, you can play with a little bit. The week usually starts from Sunday through Saturday. So if the patient is twice a week, you can see them Monday and Thursday. Or if you feel like Mondays and Wednesday work for this patient. Also too, you and your patients will agree upon the schedule because they too and their families have things going on in their lives. But just let me tell you that a lot of times your schedule will always fall through. It's going to fall through because something usually comes up, something usually happens with your patients, their families, or even with you. So even though you make your schedule and you're thinking, this is it for me, I got it down packed for the week, it's going to be disrupted. Because you can show up at your patient's home and they don't hear the doorbell. Or you'll get excuses like, oh, I was asleep. Or maybe the TV was too loud. Some patients, they forget that they had appointments and they will double book. Like they had a PCP appointment and then you're making an appointment with them and they completely forget to tell you about their primary care doctor appointment. Which usually if the patient has a primary care doctor's appointment on that day, that's not a day that you want to go see the patient because the doctor already saw them, right? So you would usually move the visit. But your visits and your schedule will sometimes fall through. Sometimes patients get sent to the hospital by their family members before you get there. So just keep in mind that a lot of things can happen, a lot of things that can come up that will completely shatter your plans. The other downside, this one I think is the most common, is that as a home health nurse, it's very possible that you may be assigned to what is considered a sketchy neighborhood or a neighborhood that's not that safe. It's going to happen. Sometimes it's not because that is your assigned location. Sometimes it is because coverage is needed. Like you may have, let's just say for example, Anne is the covering nurse for the blue team. Blue team is not in the best area, right? But Anne is out on maternity leave, but her patient still needs to be case managed and seen. They're going to split up her assignments and her patients and assign it to you, causing you to have to venture into that area that you may not feel safe, all right? And I am the kind of person where I just think as a home health nurse, you just have to be really street smart and you have to use a lot of common sense when it comes to going into neighborhoods that are a little bit sketchy. Even though a neighborhood is sketchy, it is not a reason, I don't think it's a reason to say, oh, I don't want to see that patient or I can't see those patients because of the neighborhood. As nurses, that's kind of discriminatory if you ask me, because of course you do have neighborhoods that don't have the best reputation. But like I said, a lot of common sense, not a little bit, common sense and just being really strategic can get you through to that. For example, here in Baltimore, I preferably liked to be assigned to the city. Usually that's the neighborhood that most other nurses would consider unsafe. I personally like that population of patients, so I would always be like, yeah, I'll do it, or that's the assignment that I want. what I would do is I would call my patients the day before, and I usually schedule them early in the morning. Like, I make them my first visits, because after a certain time, I'm not going into that neighborhood. That's just being smart. And I will say that usually if you go into a neighborhood that's a little bit sketchy or a little bit unsafe or what have you, a neighborhood that has maybe like a high crime or something like that, I never encountered any problems, and I don't think most nurses encounter issues. I think once you go into the neighborhood and they see that you are a healthcare professional, they're usually like, oh, okay, this person is here to help. Or the neighborhood folks are usually know that, all right, there's a grandma that lives in this building who needs care, and that's where this nurse is going, so we're not going to bother her. For the most part, for me, whenever I go into a neighborhood that's a little bit sketchy, like, I park my car, I don't really worry about it. Obviously, I don't leave any goods in my car, anything visible that will cause someone to want to break into it. And I've had like guys on the corner say, don't worry, nurse, we got you, we'll watch your car, whatever the case is, all right? The most they'll ask you too sometimes is, do you have any medicines on you? I got a headache, or can you check my blood pressure? Things like that. But for the most part, I say going into neighborhoods that are deemed sketchy and unsafe is kind of the downside for a lot of people. Most nurses do not want to go into those areas. Now, let's talk about the drive-in. And in combination with that, the gas prices, especially these days. Like, I'm pretty sure home health as an industry is suffering right now, because the gas prices are ridiculous. It usually takes me about $46 regular to fill my tank up. This is pre the gas price rise. Now I'm paying upwards of like $64, $66 to fill my tank. So this is not a time really to be in home health. I'm pretty sure it's very stressful for the nurses and for the therapists, and just for those going out to see patients. It's very stressful during this time because of the gas price. So let's talk about the drive-in and the distance. If you are not working for an agency that has a whole lot of patients, like if the census is not that large, you will find yourself having to drive long distances, because they just have to, that agency is a little bit smaller, and they just have to take whatever patients they get in whichever area. So usually when I did home health, I always worked for bigger companies that was associated with a hospital, so that way they had a large census, meaning that they could assign me to a specific location and I stayed within that location. Let's say that location might have covered 5 or 6 zip codes, or maybe 3 or 4 zip codes, and I know, okay, I'm in this area, so I'm just basically hopping bop, 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 from here to there to there. I'm not going from one end to another end, from this end to that end. That right there is definitely a downside, because driving long distances is very tiring, especially if you're on highways, you're encountering traffic, you're going from one end to another end. It's also a lot of wear and tear on your vehicle, and like I said, the gas prices are really crazy. So now is not the time to be a home health nurse, if you ask me personally. Now get ready for this. Keep in mind that the patients that you are assigned, some of them do not have any family members, they don't have any children, they do not have any loved ones that are nearby. You are basically all that they have and all that you have to look forward to. So you will go visit your patient, and they want to keep you there all day because they're lonely. You're nice to them. They know that you're here to help them with their chronic diseases. You're here to help them with their medication, provide some education. Like, some patients take you in as if you're their family members. Some of them will buy you things from the groceries. They'll make goodies for you. They'll say, oh, I got this and I bought one for you here. Take this. But some of them just don't know when it's time to end the conversation. So as a nurse, you have to be very strategic, and you have to have a plan on how to get out of that patient's home, because you have other patients waiting to see you, and you also want to end your day in a timely manner. So you don't want to stay in the patient's house an hour, 2 hours just chatting it up. But just be mindful that there are a lot of lonely people out there, and there's also a lot of lonely family members who also live with their loved ones who happens to be the patient. What happened to my light? I don't know what is going on. Hold on, y'all. The light just kind of... What the heck? I don't know what happened. But anyway, I'm going to continue on. I have this little daylight thingy here. I'm pretty sure the lighting now is going to like suck. Let's see what I can do to kind of make it look a little bit better. I don't know. My light just like went out. But anyway, as I was saying, you have the family members there who are also lonely, and they too, in conjunction with the patient, will try to keep you there. So just be mindful of that, be strategic, get out so that way you can. So one of the things that happens very often is that you will get to your patient's home and you realize this patient does not need home health. Who admitted this patient and why? There are specific criteria that you must meet in order to be admitted to home health. For example, you have to live in a home, you have to have a home phone, you have to have a teachable family member or friend, a neighbor, somebody who is able to receive the education to support you in the absence of the nurse. Because not like the bedside, nursing in home health is not 24 hours. Yeah, you can call in if you have an emergency and get a nurse to come out, if there's a nurse to come out, but it's not 24 hours. So you need to have a family member that if you as the patient is not able to receive the teaching or demonstrate the teaching, you need to have someone that we can teach. So as a home health nurse, you're not always the one doing the admission. There is usually admissions nurses responsible solely for doing admissions. And sometimes they go out and they will admit patients that do not belong in home care. And you get there and you're like, why did you admit her? She's 96 years old. She's nonverbal. She's had this wound for the past 3 years. The family members already know how to take care of it. She takes no medications. Why did we admit her to home care? Now, when the patient gets discharged from the hospital, sometimes the case managers, the social workers, they can become a little bit overzealous, even the physicians, and order home care. But as home care nurses, when we show up to the home to do the assessment, we can say this patient is not eligible to receive home care. Like, what are we going to do with her? But this all ties back into money. So some agencies will pay their nurses based on the amount of admissions that they did. They pay you per visit. So for example, if I'm the admission nurse and I show up to a patient's home, I very well know that this patient does not need home care, but I will go ahead and admit her so that way I get paid for the visit because I did all of the research. I drove to her home. The family member is there. All the paperwork is there. I'm not going to say this patient is not going to be admitted because guess what? Then I'm not getting paid for that. So I'm going to admit the patient, and the case manager who's going to follow up and visit that patient weekly, they'll figure it out on their own time. So you will show up to a home sometimes and you will say, this patient does not need home care. Or you will show up to the home and the patient is like getting dressed, putting on his sneakers, saying that he's going to go meet his friend to go fishing. And you're like, what? Fishing? You're homebound. Like, you're considered homebound when you're on home care, meaning that you're not supposed to leave the home for extracurricular activities, sir. You can leave the home to go to doctor's visit. You can go get your medication. You can go to church and big events like graduations, weddings, funerals. But to be going fishing, absolutely not. To go and walk the mall, absolutely not. You more than likely do not need home care. And in that case, you as the case manager will end up discharging that patient, and that's like a waste of your time. So for me, that was always something that annoyed me, that we had a patient, I went to go see a patient that was admitted that should have never been admitted in the first. The part that every home health nurse knows about. If you are a home health nurse and you're watching this video, drop me some comments. As a nurse, a case manager, you get to the patient's home and the patient is taking 1,000 medications. And you are responsible for reconciling, updating, and documenting in the system all of the medications. You have some patients that are taking 30 medications and then have the audacity to have 15 other supplements on top of those medications. Medication reconciliation and medication management is the biggest challenge of a home health nurse because medication errors, improper medication administration, improper dosing, improper administration, all of those things contribute to hospital emergency room visits and hospital readmission. So for the admissions nurses who work in home health, when they go out, they do the initial reconciliation. And I'll be very honest with you, a lot of them will drop the ball because they figure, this is the mindset, and correct me, you guys, if you have experience in home care, correct me if I'm wrong. And no shade to the admission nurses, but some of y'all be doing too much. But they will go and they will see that the patient has 17,000 meds and they'll only document 500 of the meds. And they'll say, I'm not coming back. She has a case manager assigned to her. They can take care of it on the future visits. So like you go in and weekly, as a home health nurse, you're supposed to review your medications, reconcile them. On every single visit, you have to ask the patient any new medications, any changes in your medication regimen, so that way you can update it in the system. So when the patient gets admitted, you make your first visit, you do a medication reconciliation, and you compare it to what the admission nurse put into the system, only to find out, girl, you didn't document the other 12 bottles that she had in this Ziploc bag. Like literally, patients have so many medications, which is why too, it's super important as a home health nurse to tell your patients, if you are no longer taking this medication, get rid of it, okay? I don't need to see it. Do not pull it out when we come on a joint visit with my manager. Like, put it away, get it out the house, give it to somebody else, give it back to the pharmacist. Just get rid of it. Some patients will pull out Ziploc bags of medications, all right? Sometimes too, they will tell you, they won't disclose everything that they're taking, and you'll do a visit and you'll see a random bottle sitting on the side and you pick it up and it's like metoprolol 12.5. And you're like, you're taking metoprolol? And they're like, oh yeah, the doctor just prescribed that 2 weeks ago. Well, when were you going to tell me? I asked you last week if you had any new meds, and nothing. This light is not letting me be great at all. I don't know what's going on with it. But yeah, as I was saying, medication management is the biggest obstacle in home care. It is one of the reasons why I was like, I can't keep doing this. I am back and I am so sorry. I don't know what's going on with my ring light, but I am wrapping it up right now. I am using the little light, like I said, my mom bought me, but I don't know what this is going to look like once I upload it to edit. But anyway, the last downside of being a home health nurse, and everyone will agree with me on this, is the documentation. The documentation is ridiculous and it needs to be revamped, or else home care will not be able to retain or sustain itself, because the documentation is out of this world. It is unlike anything I have ever seen. So for example, when you see your patients on a weekly basis, you fill out a simple weekly assessment sheet. That is not the problem. The problem is the admissions documentation, which is usually, I think when I was working in home health, it was about 33 pages long, and I'm pretty sure it's gotten longer since. The discharge documentation isn't too bad, but still annoying. The recertification is when you want to extend your patient to get more home care. And the reassumption of care. This is when a patient goes to the emergency room while on home care. They still end up in the emergency room and now they're coming back home. You have to resume home care. Those admissions, those documentation has questions that must be answered a specific way for billing purposes and for Medicare purposes. And because it has to do with money, and because they're so specific, the documentation I'm talking about is called the Oasis Documentation. So in home health, when you hear the word Oasis, run. Most home health nurses know what I'm talking about, because that documentation is no joke. You will complete your documentation, you will submit it, it goes through a quality check, and if they find deficits, they'll send it back to you to correct it. Some agencies are pretty good to where they have their quality team change the answers and you just sign off on it, which for me, I don't care. Y'all say it needs to be this, change it, I'll sign it. I do not care, whatever, okay? It's for billing purposes. You guys know better than me. You were certified, trained, whatever. Change it, code it, I'll sign it. But some agencies, they send it back to you for you to make corrections. And it will be something like, I'm trying to find an example. So your patient uses a walker, or your patient doesn't use any devices to ambulate, but they hold on to the staircase. You can't deem them ambulates independently. Like, that's not considered independent ambulation in home care because they're using the staircase. So you have to select uses assistance or something like that. Like, it's just a very, it's like a mindset thing. It's like a very weird way of thinking and answering the questions that most nurses who are new to home care, who get trained to do an Oasis, once they get on their own and they start doing it, they're like, man, forget this. I can go back to the hospital. If I'm a med-surg nurse, I can do one documentation, one assessment a shift, submit it, whatever. If I'm in the ICU, I do Q4 assessments and I'm good after that. Like, no one is really on my back, sending me back consistently, constantly. I'm getting emails, submit. Oh, you didn't change the answer, sign off on this. Like, the documentation in home health, they got to do something about it. It's too much. I don't know what else to say other than that is the biggest reason why I think a lot of nurses don't stay in home health. But anyway, thank you guys for watching. I know the light quality might not be as good, but I do appreciate you sticking with me through this video, and I will see you all in another video.